Decades
Hello,
prior,
and good evening, everyone.
scan was just a picture in textbook. Then a savior taught diagnosing almost everything in chest. With a mere conventional X-ray, not even digital like today. He wasn't a radiologist, but a pulmonologist. The master is here today for the second time in CCI webinar history to quench your thirst. I proudly welcome Dr. G Ravindra Babu, sir, from Vishakapatnam for today's masterclass CCI webinar.
Hello, and good evening, everyone. Welcome to another wonderful webinar by CCI. I thank CCI founder, Dr. Anish Krishna, and the pillars, Dr. Narayan Pradeep, Dr. Adri, Dr. Ravidosi, and the webinar coordinator, Dr. Vishakapatnam, the current office bearers, Dr. Ashish Dubey and Dr. Anil Maske, for their relentless efforts in conducting regular weekly academic sessions for the past close to 2 years. Personally, this is the best day of my career, and I cherish this day all throughout my life as I'm here to moderate session by our guru, our guide, our mentor, Dr. Ravindra Babu Garu. Dr. Ravindra Babu Garu was a superintendent of Government Hospital in Chest and Communicable Diseases from Andhra Pradesh from 1995 to 2003. He was a professor. He has retired as a professor and HOD as in the Department of Pulmonology from Andhra Medical College in August 2009. And we are blessed to be his students as he was HOD when we were doing our post-graduation in Andhra Medical College. And from 2012 to 2021, he was a professor and HOD at the Department of Pulmonary Medicine, NRI Institute of Medical Sciences, Vishakapatnam. Laid back in 1987 only, he received Dr. Vishnatham Prize for University First in DPCD. He received Best Paper Awards twice in state conferences, TB and chest diseases in 1987 and 1988. Also, Sarojyoti Award for Best Poster in National Conference for Respiratory Diseases, 1989. Dr. O.A. Sharma Endowment Lecture Award, 1993. Dr. Koteshwara Endowment Oration Award, 1999. Pulmonology Oration Award from IMA Vijayawada in 2009. And Professor A. Chakrapani Rao Memorial Oration Award in the year 2019. He conducted various chest X-ray quiz multiple times in various national conferences, and he gave multiple lectures in chest radiology. Majority of the times in all national conferences, and more than 10 times in various national conferences. And he has a special interest in critical care. With that interest in critical care, he is the person who started critical care department in Andhra Medical College in Government Chest Hospital, which saved lives of thousands of people during COVID. And he is a founder chairman of ISCCM Vishakapatnam chapter. He is the chairman of Operational Research Committee of RNTCP AP State from 2015 to 2017. President of Association of Pulmonologists of Andhra Pradesh 2017 and 18. During our postgraduate days, we used to roam around in conferences with so much pride and confidence as Dr. Ravindra Babu said students, because everyone used to be jealous of us because we used to have slight edge over there in chest radiology because he is a legend in chest X-ray and he used to show us few of his collections during our postgraduate days. Today, again, to be his student and to listen his guest lecture on chest X-rays, it is a great opportunity for me. It is to revisit my good old days. So I take immense pride in welcoming Dr. Ravindra Babu Garu for another great session on X-rays in ICU. Welcome, sir.
Good evening, ladies and gentlemen. At the outset, I thank Dr. Ashish Dubey, National President, Dr. Anil Maske, National General Secretary, Dr. Vishakapatnam, the coordinator of the webinar programs, who was my student once upon a time, now is a good friend of mine. And profound thanks to Krishnaji and Narayana Pradeepa for finding this CCI and allowing a dissemination of knowledge to everyone. The portable chest radiograph is one of the commonest investigations done in ICU for critically ill patients. See, the anteroposterior view, that is the AP view, taken when the patient is lying down on the bed in a supine position, with a 3 feet distance from the tube to the film is usually considered inferior in quality compared to the gold standard PA view, which is taken in erect with a 6 feet tube and film distance in our routine practice. But in spite of the poor quality of the portable chest X-ray image, one has to interpret it properly, to intervene immediately to save the lives of the patients in some very critical situations. So everyone who is attending the patient, like a sister, a resident, a respiratory technician, pulmonologist, anesthesiologist, in sense which a consultant, everybody must know how to interpret the portable chest X-ray, because the radiologist may not be available immediately and always during the critical times. Let us see how it differs from a PA view. For example, this is an AP view. You can see both the domes are elevated. Usually, it should be at least at the 5th anterior rib. You can see here it is only at the 4th rib anteriorly. See, the domes are elevated because usually we give instruction for the patient to take the deep inspiration and then hold it. Because most of the critically ill patient may not be able to take a deep inspiration and hold it because of the breathlessness or pain or because of the distension of the abdomen, etc. Particularly in the lying down position, the intestinal content pushes the domes upward. So most of the time the domes are elevated, obscuring most of the lower lobes. Next, you can see the scapula. They come into the picture. So in spite of their presence, you must be able to interpret the pathologies. Next, do we take portable chest X-ray routinely in every patient? This American College of Radiology appropriateness criteria for routine chest radiography in intensive care units 2014. Their guidelines say for appropriate clinical indication only. For example, whenever there is a clinical iteration, the dropping of the saturation or change in the peak pressures or the plateau pressures, then only you should take a chest X-ray. And every time after placement of an endotracheal tube, nasogastric tube, feeding tube, or a chest tube, or a CV line, or a Swan-Ganz catheter. So after any process, you have to take a chest X-ray. So do IPAP every day. This is the term I coined. See, you should always, everybody, particularly all the junior doctors who are attending the patient, do inspection for the movements or for any fullness or bulging due to any pneumothorax. And palpation, particularly in ventilated patient, you should always palpate the neck for the subcutaneous emphysema, because most of the times early surgical emphysema can be palpated. Then auscultation for breath sounds and any adventitious sound like wheezing, etc. And then only do percussion. If there is a need for a percussion, then you do. If there are absent breath sound, then do it to see whether there is resonant suspecting pneumothorax or a dull note suspecting collapse or pleural effusion. Now, these are the factors you should always look for. So the rotation, it should be properly centered. See, the spines which you see through the vertebra, they must be equidistant from the medial ends of the clavicles, as you see in this picture. Now, for example, this is the correctly taken X-ray. You can see a total lung consolidation with the air bronchograms on left side. Whereas this one, see, almost looks like a collapse, but it is also a consolidation mimicking a collapse, because the patient is rotated towards that is the medial end of the clavicle. The patient is rotated towards the left, and all the anterior structures they go along with the clavicle. You can see the clavicle is away from the spine. All the anterior structures like the cardiac borders, cardiac heart as well, they go along with the clavicle. So now you see the consolidation looks like a collapse. And the same patient on the next day, it looks like a pleural effusion with a consolidation because the patient is now rotated towards the right. You can see along with the clavicle, you can see the right heart border and the part of the right heart moving to the right side, giving the spurious appearance of the pleural effusion. So check rotation whenever you interpret atelectasis or effusion. Exposure or penetration. So this is unless penetration is good. For example, in this picture, you see a soft opacity on the right side, and it looks very dark on the left side. Now with the proper interpretation, so even this is not good, but you can see a faint opacity again, but the breath sounds are good. So sometimes you may not be able to repeat, but the exposure factors are previously used to difficult. We have to repeat the X-ray. Nowadays, because the computerized radiography is used in the portable also, sometimes even the DR systems, particularly during the COVID time, the exposure factors can be adjusted in the film itself without further exposure. Now you can see clearly the left side lung also, it is quite normal. Right side, there is an opacity. Likewise, you can see a darkness and a translucency on the right side, looks like some sort of pneumothorax. But when the exposure is correct, you can see clearly the visceral pleura and the right side pneumothorax, and left side lung is normal. Likewise, here the consolidation in the right upper lobe is very well seen, but we don't know what is there in the left side. But now when the exposure factors are adjusted in the computer itself, without taking further this thing, you can now clearly see the left lung is quite normal. Now another problem with the exposure, see this is a child with the ARDS. Now the exposure is too much, the penetration is too much. It gives a spurious appearance as if the opacity is clearing and the patient is responding. So you should see whether the patient is responding with the pressures you get, the complaints and other factors, and also the saturation. You should not depend on the X-ray. For example, this one, bilateral ARDS in an adult. Again, this is the overexposed film giving as if the opacities are clearing. But when adjusted for the exposure, you can see it is almost same. So it is better to underexpose the film than overexpose, because even if with the underexposure, the consolidations look like consolidations only. Whereas with overexposure, you don't know whether there is a pneumothorax or something else. Particularly in emphysematous COPD patients, very difficult to interpret. So never read an overexposed film. Nowadays it is easy because the computerized radiography is there. You can adjust in the reader itself. And don't hesitate to repeat an overexposed film. And pleural effusion. See, pleural effusion in erect view, in erect PA view, it will give rise to a meniscus pattern with obliteration of the domes usually. This is the usual picture of a pleural effusion in a PA view. Whereas when the patient is lying down, see the pre-effusion is just freely moves from apex to the base of the lungs. You can see here. Now this is the meniscus pattern in the erect view. So when the same patient is lying down, you can see the meniscus pattern disappears and you'd see a diffuse haziness over the entire left lung. So it is not as dense as the liver opacity see, nor as translucent as the other lung. So it is the in-between opacity because there is a pleural effusion as well as the normal lung. You can say it is somewhat looking like a ground glass opacity because through it you can see the vessels behind in the lung. Now this is the infrapulmonary effusion on the right side in an erect patient. And when the lying down, you can see a diffuse haziness, a ground glass opacity dispersed. So you should not think this is a consolidation and start injection meropenem, etc., etc. Now I can say clearly a diffuse ground glass opacity, you can see the vessels through it. So this is not a consolidation. No, there is no air bronchogram. In spite of so much opacity from apex to the base, the dome is not obliterated, the heart border is not obliterated. So this faint opacity is due to free fluid. And the lateral decubitus X-ray is confirmatory, or nowadays you can use the ultrasound to confirm the diagnosis. Another patient, you can see the diffuse haziness, again, from apex to the domes, you can clearly see the heart border as well as a diffuse fuzzy diaphragmatic. The diaphragmatic border will be obliterated, the effusion is too much. Again, on the left side, you can see a hazy opacity, almost mimicking a consolidation. Again, see the cardiomegaly is there, and some sort of interstitial edema is there. You can see bilateral effusions, a haziness on the right side, and also haziness on the left side compared to the claustrophrenic angle. Again, a faint opacity you can see on the left side, not on the right side. Right side lung is normal translucency, whereas a faint ground glass opacity on the left side. So this is an effusion, free effusion seen in the supine film. So that you should note how a pleural effusion differs from the PA view. Again, this is an effusion. Again, you can see this is the RTA case, road traffic accident. You can see multiple rib fractures. Here it is very important to recognize the effusion because it is a hemothorax. And once you recognize, you must be able to, put the tube immediately to drain the hemothorax. Otherwise, if you think it is a consolidation and put antibiotics, then it will not do good to the patient. You can see the rib fractures as well as a faint uniform opacity throughout the right lung. Again, magnified view, you can see the faint opacity. You see, it is not as dense as the liver tissue or the heart tissue. It is in between tissue because the overlying lung is superimposed over it, which contains air. So this is the combined air and fluid opacity, which is giving rise to such a faint opacity. Again, you can see another effusion, but you can see some sort of meniscus pattern in the lower part also, helping us to, you should not think this is effusion and that is consolidation. You should always see whether the whole thing is effusion or the effusion is associated with some sort of consolidations or contusions in case of RTS. See, you can see in the right lateral decubitus, there is an effusion. Also some sort of consolidation is there in the right middle zone. And what is this? See, this was diagnosed as ARDS, and then they called me. So you can see faint opacities on both sides of the chest, of course, always mimicking an ARDS. You can see the left lateral decubitus is taken. The whole of the right lung is now clear because the fluid has gone into the mediastinal part. And again, right lateral decubitus seen. Now you can see the whole of the left lung is seen. So there is nothing like an ARDS anywhere. So these are bilateral effusions mimicking an ARDS. So sometimes pleural effusion can present as a diffuse homogeneous opacity, which you have seen now with an apical cap. You can see here bilateral opacities are the faint opacity. That is left side also, it is not normal lung. There is a faint opacity there. But we can see the apical cap there. You can see the widening of the apical pleural line. So in any faint opacity, you should always look for this one because that is one of the signs of a pleural effusion in a supine film. You can see the apical cap here. And when the fluid is too much, see there will be parietal pleural widening also, apart from the apical cap. You can see here on left side, you can see the apical cap as well as it is coming down as if there is a reverse meniscus sign. And you can see the parietal pleural widening. Again, you can see too much fluid. The whole dome is obliterated. And you can see the parietal pleural widening and also almost a meniscus pattern because the fluid is too much here. And this is consolidation. You can see the patchy nature. It is not a uniform ground glass opacity. It looks like some sort of ground glass opacity inferiorly, but upper lobes you can see it is as dense as the heart and the liver. And you can faintly see the air bronchogram also clearly. So that is a consolidation. You should not get confused with the pleural effusion. Again, two in the same frame, a consolidation on the right side and effusion on the left side. You can see the faint uniform opacity with underlying vessels seen, whereas air bronchogram is clearly seen in the right sided consolidation. Again, the left side consolidation, you can see a different opacity, a more dense opacity, obliteration of the heart border. Here a faint opacity, uniformly dense, not as dense as the heart opacity or the liver opacity. So what are the signs of pleural effusion in a AP supine film? So initially there may be blunting of the costophonic angle, there may not be. Diffuse haze over the hemithorax. You saw so many films of the ground glass opacity, an apical cap, and the parietal pleural widening. When it is more, so apart from the apical cap, the apical, the parietal pleura will also get widened. And lateral decubitus film on the same side or the ultrasound scan will be confirmatory. See, the elephants are lucky. They will not have any pleural effusion because they don't have any pleural sac. The pleural sac is replaced by a connective tissue. So they will not have any, they will not develop any pleural effusions. And pneumothorax. So pneumothorax also differs, particularly when it is early. You can see clearly when the pneumothorax is more, you can see clearly the visceral pleural line. So there is no doubt here. And you can, in this X-ray also, you can clearly see the visceral pleural line and then you can easily diagnose the pneumothorax here. And see tension pneumothorax. So usually in a tension pneumothorax, the lung gets collapsed, almost like a fist-sized opacity attached to the hilum. But here you can see the lung has not collapsed that much. This is due to the PEEP we apply in a ventilated patient. Because of the PEEP, the lung doesn't collapse. So the burden is on the diaphragms usually. You can see how flattened the whole of the right diaphragm is. You can see almost there is a, what do you call, herniation of the pleural sac onto the left side. And another child, you can see almost lung. The shape remained same, almost size also same. You can see the whole of the burden has gone onto the diaphragms. So these are the cases which are very serious and need very immediate intervention. Now, what is deep sulcus sign? So deep sulcus sign. See, you can see in the cartoon here, when the patient is in erect position, so the usually air goes into the non-dependent part, that is the upper part and the apex. Whereas when the patient is lying down, usually it goes into the non-dependent, particularly the costophonic angles and the anterior costophonic angle. You can see clearly here. So this is the so-called deep sulcus sign. So compared to the left side, the sulcus is deep on the right side. So whenever you see a deep sulcus sign and the very clear diaphragm, you should always suspect a pneumothorax and confirm it with either a decubitus position, opposite decubitus position, and an ultrasound these days, and adjust your factors like PEEP, etc. And ask the sister to keep the intercostal tube set ready available immediately for any intervention. Now, this is the deep sulcus sign. One should see this is the deep sulcus sign, and the same patient, it was ignored at that time. And now you can see the PEEP, because of the PEEP, the lung has not collapsed. The whole burden is on the right dome. See how flattened and depressed it is. Now it is become a very, very deep sulcus sign. Now another case of deep sulcus sign on the left side. Another one, a very faint deep sulcus on the left. Again, a minimal left-sided pneumothorax. And sometimes, so instead on the lateral costophrenic angle, sometimes you may have air in the cardiophrenic angle, and you can see the V-shaped lung shadow because of the pneumothorax. So sometimes you can only observe these things, adjusting all the factors, because when it is very minimal, you cannot put a tube. But if the factors are very bad, then you can introduce tube blindly. But you should never use a trocar in ICU patient, particularly when the patient is on PEEP, because the trocar may rupture the lung. What you see here is the edge of the scapula. It is not a pneumothorax. The infrapulmonary pneumothorax are the double dome sign. This is, apart from the deep sulcus sign, this is one of the manifestations of early air in the supine patient. You can see a huge consolidation with the air bronchoroms on the right side and a double dome sign inferior. You can see an infrapulmonary pneumothorax. There is a, it is not a pneumoperitoneum. You can clearly see the infrapulmonary pneumothorax. And you can see the infrapulmonary pneumothorax on the left side. You can see almost half the, and also there is an effusion there, sorry, a pneumothorax and a deep sulcus sign. So there is a pneumothorax as well as a deep sulcus sign with the infrapulmonary pneumothorax. Again, a faint. So these are the things where you should be ready to do when the patient deteriorates. Again, you can see bilateral infrapulmonary pneumothorax with almost bilateral pneumothorax also. Not typical on the left side, but typical on the right side. You can see the visceral pleural line, parietal visceral pleural line, and the inferior diaphragmatic visceral pleural line, giving rise to infrapulmonary pneumothorax on both sides. Again, you can see there is a pneumomediastinum, very severe pneumomediastinum, with infrapulmonary pneumothorax, a deep sulcus sign on left side, with the continuous diaphragm sign. This is the continuous diaphragm sign. And after putting the tube, you can see most of it gets dissipated. Still the continuous diaphragm sign is seen clearly. No, this looks like a pneumothorax, but you can see the opacity on two sides of the line is almost similar. It doesn't look like a translucent one, but you can trace the line to the axilla. So this is the axillary line, anterior axillary fold, mimicking a pneumothorax. So you should be careful to see whether it is. Particularly this happens when the old people with loose muscles. Again, on the left side, almost looks like a pneumothorax here. But you can see this can be traced into the axilla, outside of the thorax, hemithorax. Again, you can see another line superimposed over in ARDS picture. Again, you can trace it to the outside. Sometimes, see, when the development, when the X-ray is developed, see the watermark, if it is not properly washed, it can just go down and present as a watermark like this here. And you can see clearly the opacity on both sides of the line is same, not that translucent. You can also see the vascular markings on the right side. Sometimes the scapular border can mimic a visceral pleural line of the pneumothorax, so you must be careful. What are the signs of early pneumothorax in AP supine X-ray? Just now we have seen the hypersensitivity above the diaphragm, a sharp diaphragm, a deep sulcus sign, infrapulmonary pneumothorax, and other side lateral decubitus film or the US scan chest will be confirmatory. Now in this patient, you can see the dome is depressed. And you can also see the collapsed lung here. But you suspect pneumothorax, but it's not as translucent as you see typically in a pneumothorax. But this opacity is not as dense as the liver opacity or the heart opacity. So this is a air and fluid opacity. See, this is how an hydro-pneumothorax looks when the patient is lying down in a supine film. So you should not get confused with other things. So you can see the opacity clearly. It is not as translucent as the normal lung, nor as dense as the liver or the heart, which happens if there is a fluid density in an erect film. Above you will see the air and below you will see a horizontal fluid level. Because the patient is lying down, this is the tension hydro-pneumothorax. Again, you can see another film. This is the tension hydro-pneumothorax again. You can see the opacity. Again, compare it with the normal lung on the left side. It is not as translucent as the normal lung, nor as dense as the liver tissue or the heart tissue. So this is the air and fluid opacity when the patient is lying down. So this is particularly important when the patient is having RTA trauma, and you should not think it is a pneumothorax only. And because there is a possibility of hemothorax, you should always put a tube. Anyway, it is a tension pneumothorax, you will put a tube. Now you can see the right side opacity is air and fluid, whereas the left side opacity is only left side X-ray shows only air. You see how translucent it looks compared to the right side opacity. Now this is the pneumothorax on left side. Now after putting the tube, you can see the opacity. This is the re-expansion pulmonary edema. So you should always let out the air with intermittent clapping. If suddenly let out the whole of the air, particularly when the patient is having a tension pneumothorax, you may get a re-expansion pulmonary edema, and sometimes even you can get the pulmonary edema on the opposite side also with life-threatening consequences. So you should always, we know clinically patient coughs, and that is the time to clamp the tube. Again, another case of hydro-pneumothorax. Again, after putting the tube, you can see the pulmonary edema. Again, re-expansion pulmonary edema on the right side after putting the tube. Again, left side pneumothorax, tension pneumothorax. You can see how flattened the diaphragm is. So immediately after putting the tube, you can see the pulmonary edema. And sometimes, even with massive effusions, when you put a tube, the same thing can happen. You can get a re-expansion pulmonary edema, even the fluid is drained very fast. Fluid usually takes some time to drain, but sometimes it happens. This is another interesting X-ray I had taken from one of the case reports in the literature. So this is the so-called fallen lung sign. See, normally what happens is, in the pneumothorax, the collapsed lung goes medially towards the hilum. So here the whole of the lung has fallen into the right hemithorax. See, this is due to the rupture of the right main bronchus. So in a case of RTA, particularly when there is a mediastinal emphysema, and the most important clue is that the lung doesn't expand even after putting the tube. See, lung will not expand. See here in this case, the tube is kept, but the lung has not expanded. So that is the time when you should suspect and do bronchoscopy. And this is the fallen lung sign, the so-called fallen lung sign. So in the same patient, you can see they kept another tube. There is a bilateral pneumothorax, the tube was there on the left side also. The lung expanded. You can see the previous film. There is a pneumothorax here. You can see this is the pneumomediastinum. And after putting the tube, the left lung expanded, but they kept another tube, second tube in the midclavicular line in the second space on the right side, but the lung has still not expanded. So that is the first time itself, when you put the tube and the lung doesn't expand, that is the time to suspect this rupture, tracheobronchial rupture. Particularly, they will have a pneumomediastinum. Some people may have a hemoptysis. And the most important clue is the lung doesn't expand. No improvement with after putting the tube. If the tube is properly functioning, then if the lung is not expanding, then that is the time to suspect a bronchial rupture. And this is my case. You can see clearly the tube is there. The lung has not expanded. Still the dome is depressed, and there is a pneumomediastinum and surgical emphysema, as well as you can see the medial border of the collapsed right upper lobe. So usually you don't see the medial borders because they get attached to they get collapsed and they get attached to the hilum. So this is because the rupture, it got separated from the hilum. And this is the picture of the buffalo. See, usually the buffaloes, they have a single pleural sac. So, particularly when the hunters, when they hunt the wild buffaloes, they aim at the thoracic case with an arrow to collapse both the lungs. These are not for the ordinary buffaloes, but the wild buffaloes in forest. And mediastinal emphysema. See the mediastinal emphysema, if it is that much, you can see clearly, even without X-ray also you can suspect that one because of surgical emphysema. You can see the para-aortic translucency clearly. But see, when it is minimal, then also you should be able to suspect. Most of the times you will have a paracardiac, the visceral pleural outline. You can see here, the outline is very clear. This is the pneumothorax. This is the mediastinal emphysema, mediastinal pleural elevation due to mediastinal emphysema. Again, very subtle sign. You can see, that's why it is very important to palpate the nodes always. You can clearly see the surgical emphysema. So you should always palpate the neck during your rounds. You can see, you may miss if you don't, because you don't routinely see the soft tissues. You may miss the opacity, but again, this is the clue. This para-aortic line is the clue. And sometimes it can be very subtle. You can see the paracardiac line here, very subtle line, almost a minimal surgical emphysema here. Again, another case with the minimal elevation of the mediastinal pleura, paracardiac pleura. Again, you can see some sort of intrapulmonary pneumothorax. Magnified view, you can clearly see the line. And also the intrapulmonary pneumothorax between the base of the lung and the diaphragm. Again, another case, you can clearly see the pericardiac mediastinal pleural outline. And also there is a pneumothorax. You can see the visceral pleura there. There's both arrows laterally. So this is a patient having severe surgical emphysema, bilateral ARDS, and looks as if there is a pneumothorax on the deep sulcus sign on the right side, as well as some sort of intrapulmonary pneumothorax. So because the patient is having a severe ARDS, so we took decubitus views on both sides. This is the right decubitus, left side decubitus view showing no pneumothorax. And again, the left decubitus, the right side decubitus view showing no pneumothorax. And after sometimes you can see the left side X-ray shows clearly the translucence is disappeared without any intervention. Now, atelectasis almost looks like same as if the same thing you see in PA erect films, not much difference. But so any opacity with an oblique line is usually a collapse. If it is in the upper lobe collapse. If it is in the lower lobe, a lower lobe collapse. If the heart border is also obliterated, it is a lower and middle lobe collapse. Usually middle lobe collapse isolated will not be seen in the X-ray. And they are not significant also. You can see behind the heart a triangular shadow with an oblique margin, a dense opacity with oblique margin behind the heart. That is how a left side lower lobe collapse looks like that. Again, you can see opacity with the dome is obliterated. So this is the left lower lobe opacity. But with total lung opacities, the image is different. You will not see any oblique margins. You will see a total lung opacity with the obliteration of the dome as well as the cardiac borders and shift of the mediastinum to the same side. You should always look at the rotation also, as we have seen in the previous films. So this is a total lung collapse on the left side. So whenever there is a total lung collapse, particularly in ICU, suspect mucus plug, tube, tooth, and tumor. Tumor is unusual in ICUs, and a blood clot. So you remember MTB, that is Mycobacterium tuberculosis, as a M for mucus plug, T, tube, tooth, tumor, and a blood clot. As I said, tumor is unusual in ICUs. So remember mucus plug, tube, and tooth and blood clot. So this is the patient. You can see right-sided pneumothorax, almost a hydro-pneumothorax. You can see the opacity is not as translucent as the right upper lobe, nor as dense as the liver. It's in between opacity. There is a hydro-pneumothorax and also the collapsed lung with almost maybe some necrotizing pneumonia there. You can see a lot of translucencies inside. And there is also right lower lobe collapse. You can see clearly the heart border clear, but the dome is obliterated. So immediately he is having only the upper lobe as the only lung functioning lung. So immediately his child, he was intubated and suction is done. You can see the mucus plug cleared, and now the right total lung is clear, but the fluid drained because previously the tube was Malicards, and it got obstructed. Again, another tube was kept. Now you can see the fluid drained clearly, and you can clearly see the translucent appearance of the only air without fluid. Now here you can see a total lung collapse. So you can see the tube coming into the right main bronchus. So when it enters the right main bronchus, see the left lung gradually collapses. See, this entered into the intermediate bronchus. So that's why there is a left lung collapse as well as the right upper lobe collapse. So these things which if you ignore, then patient will go into a distressed state. So immediately if we just pull the tube, then the whole thing will be normal. So suspect always either a mucus plug or a tube or a tooth, rarely. Again, you can see it entering into the right main bronchus, obstructing maybe the right upper lobe. I don't know whether there is any tracheal segment also. And you can see clearly a tooth here, causing a left total lung collapse. See the X-ray. So this is reported as a normal X-ray. But if you see clearly, the right dome is completely obliterated. See how clear the the left dome is completely obliterated. The descending aorta is also obliterated because there is a good penetration. You can see the vertebral spaces clearly. So you must be able to see the descending aorta clearly. So both the descending aorta and right dome, left dome are obliterated. So there is an opacity behind the heart. You can see clearly behind the heart, the heart is dense. So this is the compression atelectasis. This is not the obstructive atelectasis. This is the compression atelectasis because of the weight of the heart, particularly in supine patients when there is not much changes position. If you don't change the positions frequently. And also when we suck the patient, the suctioning catheter goes into the right lung, right main bronchus, but not into the left main bronchus. So it is difficult to suck on the left side. So this compression atelectasis happens and you may find some desaturation. What is required is only to suspect it and do some physiotherapy in a prone position, and it will get cleared and you can observe the improvement in the pulse oximetry. Now you can clearly see the descending aorta clearly after physiotherapy. Now the whole opacity is disappeared and the left dome is very clear. Now that is the compression atelectasis, whereas this is the obstructive atelectasis. In obstructive atelectasis, you will clearly see a dense opacity. The dome is obliterated, but you can clearly see an oblique line because of the collapse. Whereas in compression atelectasis, it is the lung behind the heart that is gradually compressed. Whereas this is a consolidation, left lower lobe consolidation. So this is not an obstructive collapse, not a consolidation, but only a compression atelectasis, which disappears with the physiotherapy usually. Now another case, you can see almost lungs are normal, but see it is penetrated too much. But in spite of it, you don't see the descending aorta and you are not able to see the left dome. So this is again a compression atelectasis. And with physiotherapy, now we can clearly see the dome is descending aorta, aortic outline is clear and the dome outline is clear. So all these are reported as a normal X-rays only. You can again see the left dome is obliterated. So whenever the left dome is obliterated with the normal heart opacity, always suspect this kind of compression atelectasis. Again, after clearance, you can clearly see the left dome and the descending aorta. Again, another case. So you can see the whole vertebral bodies are seen with the interspaces also, but you are not able to see the left dome at all. So this is the compression. You can also compare the density of the right side of the heart, which is left side of the heart. You can see the left side, the heart is more dense compared to the right side, and not able to see the descending aorta or the left dome clearly. So another case of compression atelectasis. Again, another case, you can see clearly there is no left dome, no descending aorta in spite of adequate penetration. Another case, no dome is seen, no descending aorta is seen. And descending aorta may not be seen, but always usually you will be able to see the dome clearly. But when the dome is not seen, then that is the time to suspect a compression atelectasis. Just put the patient in a prone position and do the physiotherapy. That is all needed. Again, a long-standing neurological patient, not adequately positioned. See, everywhere usually will put the patient on left oblique position or the right side oblique position. See, the patient just lie down supine, and after some time you can see the whole the left dome is obliterated, no descending aorta seen. This is the compression atelectasis due to the heart in the supine position. So it is very, very important to change the position of the patient every 2 hours onto the right side and also the left side in a semi-supine or semi-prone positions. And maybe it is better to keep if you allowed, even if the saturation is good, sometimes into the prone position. So look for obliteration of the left dome to exclude compression atelectasis of left lower lobe. Again, I told you tooth. Whenever you see a collapse, you should suspect there can be tooth also. So this is a patient, you can see clearly there is a deep sulcus sign on the left side, but almost a normal, there is no pneumothorax, but you can clearly see a tooth in the left main bronchus. So this is another, I don't know whether the books have given it or not. The deep sulcus sign can also be seen in obstructive hyperinflation. See, one of the signs, particularly in these type of patients. So whenever you see a deep sulcus sign, if the lung is normal, then always look for a tooth. The same patient, on the next day, you can see the tooth on the right main bronchus. It's a migrating foreign body. Now another patient, tooth, because sometimes what happens is whenever there is a loose tooth, they may go into the lung with the intubation. Again, you can see a deep sulcus sign on the right side. So whenever there is a deep sulcus sign, just remember tooth, whether there is any tooth. So if there is a tooth, then you can ascribe it to the tooth and exclude if there is a pneumothorax also with ultrasound. Again, tooth giving rise to a deep sulcus sign. Another deep sulcus sign because of the tooth here. You can clearly see the deep sulcus sign on the right side. The lines and tubes. See, you must remember some of the landmarks. The carina, usually if it is well penetrated film, you can see the carina and aortic knuckle clearly. And usually the tube should lie some 5 centimeters from the carina, or just you can say at the level of the upper part of the upper outline of the aorta. That will be an adequate landmark. Because what happens is, see, whenever the patient extends his neck, the tube moves some 2 to 3 centimeters away from the carina. And if it is not properly positioned, then they may go into the vocal cords also. And when the patient flexes his head, then the tube is pushed towards the carina. So if it is not positioned properly, then it may go into the right main bronchus, giving rise to left lung collapse. So the extension takes, because during the extension, your chin will be away from the suprasternal notch. Just remember that one. So it will move the tube away from the carina, whereas in the flexion, your chin moves towards the suprasternal notch and towards the carina. So the tube also moves towards the carina. Now, what is important? It should be some 5 centimeters away from the carina to allow this type of movements not to obstruct the. You can clearly see here, this is the carina where the tube is here. Now, this is the patient during the flexion, it may go into the right main bronchus. So, definitely it should be repositioned. That is the aortic arch. Again, another one. Again, this is the tube. So it should be pulled back. And this is already into the right main bronchus. And you can see the collapse is beginning into the left lung. Again, you see, again, almost into the right main bronchus. And there is already collapse. So initially, you may see an air bronchogram because air may enter partially. Again, it has entered into the right main bronchus. You can see from the curvature itself that it has entered into the right main bronchus, and there is a total left lung collapse. Again, same patient, magnified view. You see the carina. Again, this is an interesting X-ray. You can see here there is a deep sulcus sign. But when we auscultated, their breath sounds are very good. See, when you see the tube, it has entered the right main bronchus. So what is happening is the whole of the tidal volume is going into the right lower lobe. The whole of the tidal volume is going into the right lower lobe, giving rise to hyperinflation and this deep sulcus sign. So you can see the lung is becoming collapsed. Now, see, in this lecture, we have seen deep sulcus sign in 3 situations. A minimal pneumothorax causing a deep sulcus sign, an obstructive emphysema or obstructive hyperinflation due to a tooth giving rise to a deep sulcus sign, and hyperinflation. Maybe this is very unusual, giving rise to a deep sulcus sign. So you should do the appropriate clinical investigation to rule out what exactly happened. Now, this is the same patient after pulling the tube up. You can see now the deep sulcus sign disappeared. Now the collapse also disappearing on the left side. Now, one thing most people ignore is this is the bulb. See, the endotracheal tube will have a bulb which is inflated. And normally, it should not be seen. Say, any hypertranslucence is seen around the trachea compared to the normal trachea should be suspected as a overinflated tube. And then you should check the pressures in the tube. Now, you can see almost there is a convexity. You can see very hyperinflated tube. Now, this is ignored. So, if you are unaware of it, and if you are not in the habit of seeing regularly the pressures with a manometer, then see, ultimately what happens is these things will lacerate the trachea, and either trachea may rupture, there may be an esophageal rupture, or if it is not that much, then ultimately it may lead into granulation, scar tissue, and lead into cirrhosis. So nowadays in the CCI, we are seeing a lot of PITS cases. Most of the traumatic due to the stenosis because of the endotracheal tube. Now, these are the simple things which help us to avoid these complications. If you don't check the tube regularly, pressure on the bulb regularly with the manometer, then at least you should suspect hyperinflation in an X-ray. Now, this is a very unfortunate patient. You can see it is almost like a round ball. See, this was ignored for 15 days. Ultimately, the whole of the tracheostomic tube landed in the esophagus and the patient died. See, these are all iatrogenic and we can avoid. So what is important is first to know about them, then see the films daily for look at them. So looking at the airways takes just 1 second, but that gives a lot of information. Again, another, you can see almost a bulb, very round bulb. And this is an esophageal intubation. You can see this is the carina where the tube has gone into the, beyond the carina. And you can see a lot of gas in the stomach because the whole of the tidal volume is going into the stomach. And you can see the clearly outlined esophagus also, air in the esophagus. And you can see the bulb is away from the trachea there. Regarding the CVP line, this is the subclavian line. So you should always remember the inferior border of the first strip as the landmark. Now the tip of the CVP line should be below at least 1 to 2 centimeters below the inferior border of the first strip. It should never be above it. Lower border of the first strip, SVC, and this is the tip. See, this lower arrow indicates the correct position. So most of the studies show if it is in this position, the clotting is less. And this is the Ryle's tube. Ryle should be in the stomach. And somewhere here, you will see this esophageogastric junction. And from there, at least it should have it should project 10 centimeters beyond it. It should not be just, you cannot leave it here. It should be, and it should not cross the midline and go towards the right side. If it crosses the midline, most probably it is in the duodenum. Now this is the wrongly positioned CVP line, almost at the junction. That is the correct positioning. This is the lower arrow shows the cavoatrial junction, and the upper one is in between the cavoatrial junction and the inferior border of the first strip. The left side in the right image, it is clear. It is okay. The position is good. Okay, but in the left image, it has gone into the right atrium. So usually they may result in a lot of arrhythmias. Again, you can clearly see in the right X-ray, you can see the Ryle's tube, but in the left X-ray, in the stomach area, the Ryle's tube is not seen. You can see it here. See, these things are important. Always look at the airways and look for the shadows whenever you go there. Don't think it is not your duty. So in this case, tube just positioned beyond the aortic knuckle. But this is the right tube tip. So it will lead into, if you leave it like that, it will lead into aspiration. And the CVP line is okay. Again, another one, you can see the CVP line has gone beyond the cavo-atrial junction. And the endotracheal tube is almost in the neck. And we are not able to see any Rayleigh tube in the gastric area. You can see here. So all the three lines not properly positioned. Again, the X-ray we have seen previously, left lung total consolidation, but you can see the CVP line most probably is in the left atrium. See, sometimes the feeding lines are allowed to be kept near the cavo-atrial junctions, even sometimes into the right atrium also, when the patient requires long chemotherapy, etc., dialysis lines. Again, wrongly kept the CVP line. You can see effusion on the left side in the supine patient. And artifact. See, it looks like an effusion. But if you see carefully, the opacity is going into the soft tissues also. See, this happens because the beam is always divergent. So when it falls on the image receptor, see, the primary beam will be round in shape. And most of the times in portable machines, the cone is used to restrict the beam, to restrict the scatter radiation, and to get a good picture. The cone is used. Because of the cone also, you can get a round picture. Now, for example, if it is not centered properly, so if it is centered properly, you get a normal picture. But if it is not centered properly, then what happens is the film beyond the cone will not be developed. And you can see the whole dense opacity meniscus in a meniscus pattern corresponding to the field of the tube. Again, another case, you can see the whole of the left side is very dense compared to the right side. And you can see it is going into this. You can see this is less dense compared to this one. Now another one, you can see clearly it is going beyond. Another one on right side. Again, you can compare this density on this side with this density. You can see the whole of this thing is dense. Usually nowadays we don't see with the computerized radiology, but still the government hospitals are using old film-based technology, then you must still see that. Again, a minimal effusion. You can see the line going into the soft tissues. Of course, it's very obvious. The whole thing has gone into the neck also. Now, this is the last X-ray. Actually, this is our first X-ray. We have shown the AP film. See, as it is, it doesn't show any pathology except some right hilar enlargement. So even if there is nothing there, it may give some clue because the patient is tachypneic and with the saturation down and the pulmonary embolism is suspected. And CT angiogram was done, you can see clearly. So even if the X-ray is normal, you should not think there is no pathology there. So ultimately, summarizing, proper interpretation of the chest X-ray in ICU and prompt interventions save lives. So it is very, very important for everyone who is engaged with the critical care services, whether a sister or a resident or a respiratory technician, pulmonologist, anesthesiologist, or an intensive care specialist, to know about the images in AP portable films, and you must know how to interpret them. Thank you very much. Is a reference. Radiology assistant is one of the very good, particularly all the PGs, I advise them to go into the website and see radiography in the ICU, part 1 and part 2. And this is my favorite image. See, what do you see? If you are not attentive that much, you will just see a white jar. But if you are attentive and if you see carefully, you will see two black faces facing each other. Now, who are they? See, you can't recognize them unless you have seen them before, unless you know them. So these are the Prince Philip's and Queen Elizabeth. So even in X-rays, you only see what you know. So you cannot see what you don't know. So it is very, very important to have a proper knowledge of the portable chest X-rays to save the life of the patient. Thank you. Thank you very much once again.
Thank you, Ravindra Babu sir, for another wonderful session on radiology. Sir, your mere presence garnered close to 1,000 attendees for this webinar. It's almost 913 logins today for the masterclass in radiology in ICU. And we usually miss a lot of things in ICU X-ray, sir, but this is a very enlightening presentation, especially the double dome sign where you have mentioned majority of us will miss the small air sign under the diaphragm or beneath that. And anterior axillary fold mimicking pneumothorax, I think majority of us should be knowing the structures, what are normally present and how they extend outside the chest wall also. And your fallen lung sign, that was one of our favorite X-rays before also, because that usually no one will suspect until we know that there is certain thing like that. Sir, in ICUs, we usually do X-rays every day, but you have told that you should be doing X-rays only whenever there is any indication or not. But in ventilator cases, in majority of the hospitals, I think we are doing it every day, sir. Sir, what is your take on that? Are we over-utilizing X-rays or should we do only if it is indicated?
See, previously, the American College of Radiology advised routine X-ray every day, particularly in ventilated patients. But there was a meta-analysis done in 2009. They considered 8 trials and some 7,000 ICU patients. And they didn't see any difference between the outcomes with the routine X-ray and X-ray taken as and when required. So in the 2014, the American College of Radiology advised chest X-ray only when there is a clinical deterioration. Like, for example, if you see any drop in the saturation or any, say, increasing peak pressures or increasing plateau pressures, etc. If the patient is in a distress, maybe that is the time. In a routine stable patient, they said they don't. And that also, because every X-ray will have its own radiation,
yes,
that also reduces the radiation from the X-rays. So though it is not that much with the chest.
Yes, sir. The patient is maintaining the same peak pressures and hemodynamics are stable with no much drop in saturation. I think we can wait for repeating an X-ray, sir.
So I'm sorry, I forgot to thank you for moderating. And I also thank the Cipla respiratory and the technical people who assisted for this webinar. I profoundly thank them. Any questions?
Yes, sir. This is from Dr. Rajan Kumar from Jharkhand. He's asking what are the complications in chest X-ray after intubation in ICU patient? What we commonly encounter in an X-ray?
I think I showed it.
Yes, sir. I think you have already mentioned that because the malpositioning of the tube and so this is not hairline fracture. How can we detect in ICU X-ray? This is from someone Gurjit Kaur.
Hairline fracture.
Hairline fracture.
What?
Hairline fracture. How can we detect in an ICU X-ray? But I think if it's a hairline fracture, it doesn't require any intervention. Also, if it's a rib fracture, right, sir?
Fracture of the bone doesn't require anything.
How can we differentiate intrapulmonary pneumothorax from pneumoperitoneum?
See, generally, the diaphragm has its own width. Say, for example, it is almost like 3 to 4 millimeters. So when the air enters below it, you can see clearly because there is a contrast above and also below. You can see the width of the diaphragm. Whereas here in infrapulmonary pneumothorax, it looks like an edge because there is no contrast between the underlying liver and the underlying this thing. It will be easy because if my explanation may not be clear, but you will not miss. I think I should have shown a pneumoperitoneum X-ray also.
So this is one from Nath Saurendranath Banerjee from West Bengal. And how should we identify a right lower lobe collapse?
I told you.
Yes,
See, whenever there is an opacity with an oblique margin, then that is the time to suspect a collapse. A right lower lobe collapse, usually if it is the X-ray is clear, you will see clearly the heart border because heart border will not be obliterated and you will have a triangular shadow, the oblique margin going from the hilum to the periphery. So if the lower lobe, if the middle lobe is also involved, because if the intermediate bronchus is obstructed, then the middle and lower lobes are involved. Then the cardiac margin will also be obliterated. Anyway, it doesn't matter whether lower lobe or it is important to do the physiotherapy and do the suction and do the bronchoscopy if there is no response. And always just remember that mucus plug, that MTB, that is the pneumonic, just either mucus plug or it can be, if there is hemoptysis, it can be blood clot or it can be a tooth and a tube. Just remember them. It doesn't take time to remember. Just it takes only 1 second. Always look at the airways and see, look at whether there is, and you will get the results. Because that is what is important is that awareness.
Sir, this is from G. Venkat Mohan, Andhra Pradesh, Srikakulam. Good evening, sir. How can we differentiate between pneumothorax and large bullae and emphysema changes in a supine X-ray?
See, usually large bullae will have its own borders. Bullae will have fine borders, and usually you don't miss a bulla. But sometimes, see, when we cannot differentiate, it is always better to put a tube. It doesn't matter whether it is bulla or pneumothorax. But you should never put a needle. If the patient is in distress, if you cannot differentiate, if you can't take a CT, then always put a tube. My advice is whenever you put a tube, you don't use the trocar.
This is from Dr. Manoj Kumar from Andhra Pradesh, Nellore. Thank you so much, sir, for excellent presentation of rare X-ray films. Your chest X-ray program always makes us learn new points. And so this is one from Gujarat, Ahmedabad, Dr. Saurabh Suresh. Do all minimal pneumothorax as shown in few X-rays in this session, we need to put a tube.
Pardon?
Do all pneumothoraxes, which are minimal as shown in your X-rays, should we keep a tube, ICD?
No, that's what I am saying. See, if you monitor your peak and plateau pressures, And if the minimal pneumothorax is there, then there is no change in your saturation or the pressures. Then you will observe. So that is the time to keep ready the intercostal tube set ready and instruct all the persons who come into the next shift about this and verify the peak pressures and plateau pressure they're increasing. Sometimes you can use your percussion, and if it is increasing, then sometimes because already there is a pneumothorax, you can put a tube blindly if the patient is deteriorating. Again, no trocar.
This one is from Dr. L. Harishaw, Telangana, Hyderabad. Sir, what are the PT signs in ICU Xray?
What is that?
Pulmonary thromboembolism signs in ICU Xray.
There are a lot of signs. That the Westermark sign is there. The Palla sign, with the right main descending increase, it is very well seen. And the knuckle sign, the Fleshner sign, and also the Hampton sign. But they are rarely seen. So usually when the X-ray is normal, the last X-ray I have shown, when the X-ray is normal, and if you exclude other causes of hypoxia or other causes of tachypnea, then that is the time to suspect. Sometimes even the echo may be normal. So you have to do, nowadays, fortunately we have D-dimers, and if the D-dimer is more, then that is the time to do the CT angiography. So we don't depend on the signs.
This is from Dr. Shriram from Maharashtra. Is deep sulcus sign seen in patients only on ventilator or in all patients who are supine lying in the ICU?
Naturally, the same thing we will get whenever early pneumothorax is there. Only the patient is not on a ventilator, you can make the patient sit and take an X-ray. But this is particularly important in because there are a lot of PPs used in ventilated cases. That is important to recognize. As I told, you have seen some X-rays where there is a very deep depression of the diaphragms due to the tension. So that you should not miss.
So this is from...
The same deep sulcus sign is also seen in a massive pneumothorax. The very fact that the diaphragm is depressed shows it is a deep sulcus sign. But here it is important is very early deep sulcus sign. That is important.
In ventilated patients, right? When the patient is intubated, even very early deep sulcus sign, we should be more cautious about.
But nowadays, you can use that ultrasound.
Yes, sir.
Bedside ultrasound they are using, and they will take good results, particularly even for the intubation also. Even for the putting CVP lines. Now there is a lot of help from the ultrasound and critical care.
So this is from again Maharashtra, Dr. Neil Vora from Maharashtra. In case of pleural effusion X-ray in supine position, what happened to costophrenic angles? Do we always see blunting of CP angle?
It all depends. If the fluid is more, then the diaphragm gets obliterated and the costophrenic angle also may get obliterated. Because what is important is to see that a ground glass pattern of the opacity. Again, whenever there is a doubt, you can take a decubitus, or if the ultrasound is there, it is easy to recognize the fluid.
Yes, sir. I think minimal effusions, usually if they are present also may not make a difference in peak pressures or something. If they are reasonably close, causing the GGOs, requires therapeutic interventions.
X-ray wise, if you see something there, then it must be more than 500 ml.
Yes, sir.
Sometimes this is very important. See, if you let out 500 ml, then the patient tidal volume will improve.
This is again a non-intubated patient, minimal pneumothorax in ICU patient. When would you put a chest tube? That is already answered, Dr. Ravichandra. I think sir has already answered that. Sir, one X-ray you have shown, which is a dual pneumothorax on both the sides, which was mimicking the dual pneumothorax on both the sides. But of the lateral, once the opposite lateral decubitus position X-ray was done, it was there is no pneumothorax. One X-ray which you have shown in the presentation, sir. I think, but that lateral decubitus X-ray when the patient were not able to shift for the CT, I think that is still very useful lateral because we almost have forgotten doing that lateral decubitus X-rays. In case of minimal pneumothorax, if the patient is slightly hypotensive or something, instead of shifting the patient for CT, so will it be definitely useful to do opposite lateral decubitus X-ray?
Sure, that will be useful. You will be able to see. See,
Yes,
the case I have shown, they were taken in the next day just to demonstrate how the lateral decubitus shows, because there is not that much deterioration in the patient.
Okay. And there are few questions, but I don't think they are related to ICU X-rays or how to work out a mitral and nodule and other things.
Okay, then we'll conclude.
This is from Dr. S. Jayaraman, Tamil Nadu. Fantastic presentation, sir. Thank you, CCI, for the wonderful sessions. So what are the one more person? This is from Yogesh Kumar Arya, Chhattisgarh, Raipur. So what are the X-ray signs of pulmonary edema in a supine X-ray?
Pardon?
X-ray signs of pulmonary edema in a supine X-ray.
Same, because the pulmonary edema and ARDS and the bilateral pneumonia I have not taken because they don't much differ from the PA erect film we see normally. But in a pulmonary edema, see the pulmonary edema, if he is having bilateral effusions, then you can have a faint opacity, ground glass opacity throughout the chest, along with the interstitial markings or the airspace opacities. That's why in a case of pulmonary edema or ARDS, if you suspect pleural fluid, nowadays see ultrasound, bedside ultrasound can rule out effusions. If there are effusions, then most likely you will suspect a pulmonary edema because ARDS usually doesn't have effusions. If there's substantial effusion. So even if you don't see much signs in chest X-ray, you can do an ultrasound, routine ultrasound.
Yes.
And I also advise, say whenever the cardiologist, whenever they do the echocardiography, always ask them to look at the effusions. You just advise as a consultant, whenever they do the echocardiography, particularly in ARDS patient, let them just have a look at the and both sides to exclude any effusions.
So this is from Dr. S.K. Toke, Maharashtra, Pune. How to differentiate between fluid and consolidation and X-ray in supine position?
I told you in the uniform ground glass opacity without any patchiness or without any air bronchorams. Usually you think of a fluid. And it is easy, you take a decubitus or you just do an ultrasound. You will find the fluid. You may find the consolidation also along with it if it is there. So nowadays even all the pulmonologists also should know how to do the ultrasound.
Yes, sir. I think we have answered almost all the questions. Yes, sir. We are done with the questions, sir.
So once again, I thank the organizers as well as the Cipla Respiratory for giving me this opportunity to present this webinar. And my advice to the juniors is, see, you must all know how to read a chest X-ray. Don't depend on the radiologist because you are the proper person because you know the history, you have seen the patient. and you can interpret better. And the radiologist, see, nowadays they don't have any time, because see, they see a lot of cases. They see CTs, they do ultrasounds, they do MRIs, etc., etc. And very unfortunately, we don't give them any proper history. So we are supposed to interpret whether it is a normal PS in our routine clinical practice. Particularly, it is very, very important that we should know everything about a portable chest X-ray, because, as I told, a pneumothorax, particularly if you don't recognize, and I showed some the inflated cuffs in some patients where they lost their lives because just we ignored. So these are the things which save the lives of the patient, and we must be able to interpret them. Don't leave everything to the radiologist, because we don't have the time sometimes. So
Sir, one last
it is not that
question.
difficult.
One last question, sir. It's from Dr. Jahid, Andhra Pradesh, Guntur. In case of massive pneumothorax with ICD, how frequently do we need to do intermittent clamping, and when to decide to clamp to prevent re-expansion pulmonary edema?
See, what we used to do is, we used to, after putting the tube, some amount of air goes. Then we usually clamp the tube and ask the sister to remove the clamp every half an hour initially, and let out the air. So after sometimes the patient is stable, then we'll just, she will be roughly knowing how much air is let out. But if you suddenly let out the whole air without clamping it, then the problem comes. Most of the times the pulmonary edema will be there. It may not harm. But sometimes if there's a massive pulmonary edema and if the opposite lung is particularly bad, then the problem comes.
This is specifically in ARDS patients or something. If the remaining lung is flooded with again pulmonary edema, then will worsen despite keeping an ICD. Yes, sir.
Anything
We are done with the questions, sir. Sir, one more question. In very large bulla, if need aspiration, what will happen? Sir, I think you have already answered this, because if we are suspecting a bulla or pneumothorax, it's better to keep an ICD rather than keeping a needle.
Whenever there is when you can't differentiate whether it is bulla or a pneumothorax, and the patient is in distress, then put a tube. If you put a needle, what happens? And if you remove it, then the bulla will deflate into the peritoneal cavity, and then it produces the pneumothorax.
Yes, sir. We are done with the questions, sir. Thank you, everyone, for such an attentive hearing and a lot of questions which cleared majority of our doubts. And thank you once again, Ravindra Babu sir, for such an enlightening session, which we really, majority of the time, despite knowing all these, we'll tend to forget. And this is really an enlightening session for us. Thank you very much. Thank you, CCI, for all the efforts kept to continue all these programs, academic programs, every week without any interruption. Despite having festivals, despite having all issues, also you're continuously running the programs, and hats off to the entire CCI team. Thank you the technical team and Cipla for associating with CCI to run the program uninterruptedly. Thank you, everyone.
Okay, thank you, Chaithanya.
Thank you, sir.
Cipla Respiratory. Thanks to the organizers, and thanks ultimately to Krishnaji. Thank you very much.
Yeah, thank you, sir. Good night, sir.
And happy Diwali.
Thank you, sir. Happy Diwali, everyone, in advance. Thank you.